Good morning. So today our class is bacterial infection of skin. So here we are going to discuss about bacterial skin infections. We are going to talk about introduction, etiology, classification of pyodermas, disease caused by Corynebacterium bacteria, and management of bacterial infection. So let's see the introduction or like pyoderma. What is pyoderma? So bacterial skin infections are broadly termed as pyodermas and non-pyodermas. The spectrum of bacterial infection it varies from country to country. In India, pyodermas, cutaneous anthracis, cutaneous TB, and leprosy still remains. Now, what is pyoderma? It is a common purulent infection of the skin which is caused by Staphylococcus or streptococcal organism. 80% of the children in India are affected by pyoderma. Primary pyoderma is due to direct infection of skin, and secondary is due to the secondary which is to the pre-existing dermatosis. So primary pyodermas means which occurs to the skin directly by the organism, and secondary pyodermas means it is due to one secondary infection or any pre-existing dermatosis. Primary pyoderma is caused by streptococcus and they are mainly impetigo, ecthyma, erysipelas, and cellulitis. We'll come to this in detail. And primary pyoderma is caused by staphylococcus or impetigo, folliculitis, furuncle, and carbuncle. So there is a difference between streptococcal and staphylococcal pyodermas. Those caused by streptococcus and staphylococcus, there is a common factor, and that is impetigo. Otherwise, streptococcus can cause ecthyma, erysipelas, and cellulitis, and staphylococcus can cause folliculitis, furuncle, and carbuncle. Elaboration of toxins by Staphylococcus aureus causes lesions of bullous impetigo and Staphylococcus scalded skin syndrome. So, Staphylococcus aureus toxins it can produces bullous impetigo and Staphylococcus scalded skin syndrome. Most common form are impetigo and folliculitis. Primary pyoderma are divided into follicular and non-follicular pyoderma for clinical purposes. Follicular ones are the ones which affect the hair follicle, and the primary pyoderma so it can be divided into two, that is follicular as well as non-follicular forms. Next is coming to the etiology of the causative agents. That is mainly Staphylococcus aureus, group A Streptococci, Pseudomonas, or there can be a mixed infection. Predisposing factors are preceding skin lesions, example any cutaneous injury, or hot humid climate, poor hygiene or malnutrition, in case of obese children or obese people, diabetic and immunodeficiency disorders, long-term steroid therapy, and chemotherapy agents, radiation therapy. All these are the main etiology. So the main thing is you have to remember is causative agents are Staphylococcus aureus, group A Streptococci, Pseudomonas, and the mixed ones. Next is classification of primary pyoderma. So how can you classify pyodermas? It can be classified into non-follicular and follicular pyodermas, as I told you before. The follicular pyodermas are superficial folliculitis, deep folliculitis, furuncle, carbuncle, and abscess. So all these are mainly affecting the hair follicle. So it is by superficial folliculitis, deep folliculitis, furuncles, carbuncle, and abscess. Non-follicular pyodermas are impetigo bullosa, impetigo contagiosa, Staphylococcus scalded skin syndrome, ecthyma, cellulitis, erysipelas, paronychia, and erythrasma. So what are the non-follicular pyodermas? Non-follicular pyodermas are basically impetigo bullosa, impetigo contagiosa, Staphylococcus scalded skin syndrome, ecthyma, cellulitis, erysipelas, paronychia, and erythrasma. Classification of pyoderma. So primary pyoderma, first we'll tell about impetigo. So impetigo, it can be superficial. Impetigo is always superficial, and the deep form of this impetigo is known as ecthyma. So impetigo, there is the superficial impetigo is mainly two types: bullous impetigo, which can be caused by Staphylococcus aureus. and the bullous impetigo can also be caused by gas. Then there is a deep ecthyma also. The deep one, which is known as ecthyma. Coming to folliculitis, superficial, there is something known as superficial folliculitis, which is known as Bocard impetigo. Bocard impetigo, which is caused by Staphylococcus aureus, and the deep folliculitis, which is known as Psychosis barbae, which is again caused by Staphylococcus aureus. Furuncles and carbuncles caused by Staph aureus. Erysipelas, cellulitis, paronychia, and erythrasma. So in all this, erythrasma is caused by a bacteria known as Corynebacterium mylotismum. So the main thing you have to remember is most of this pyodermas are caused by Staphylococcus aureus. So once more I will tell, the superficial one is impetigo and the deep one is ecthyma. Coming to folliculitis, superficial folliculitis also known as Bocard impetigo, deep one is Psychosis barbae. Then other than that, you have furuncles, carbuncles, erysipelas, cellulitis. Erysipelas is the superficial part and cellulitis is the deeper version. Paronychia and erythrasma, which is caused by mylotismum, Corynebacterium mylotismum infection. Next, other forms of classification. Superficial pyoderma, that's superficial skin infection, which is impetigo, superficial folliculitis, and disease is produced by Corynebacterium bacteria. Deep pyoderma, which is the deep skin infection, and they are ecthyma, Psychosis barbae, chronic folliculitis of leg, furuncle, carbuncle, and soft tissue infections like erysipelas, cellulitis, and abscess. The main difference of erysipelas, cellulitis, abscess with that of furuncle, carbuncle is erysipelas, cellulitis, abscess. All these are the soft tissue infection, while the other one, it is caused only in the hair follicle. Coming to secondary pyoderma, as I told you before, secondary pyoderma can be caused by, which is secondary to any pre-existing dermatosis. And secondary pyodermas can be caused by burns, insect bite, infection like scabies, dermatophytic infections, eczema, chronic ulcers, trauma, and vesiculobullous diseases. Where the typical morphology of pre-existing lesion may be masked by signs of inflammation. Next, clinical variants of pyodermas that are hidradenitis suppurativa, dissecting cellulitis of scalp, infected sebaceous cyst, infectious gangrene, necrotizing ulcers, and tropical ulcers. So these are the clinical variants of pyoderma, which is again like hidradenitis suppurativa, dissecting cellulitis of scalp, infected sebaceous cyst, infectious gangrene, necrotizing ulcers, and tropical ulcers. Next, superficial skin infection versus deep skin infection. The superficial skin infection are more common and are characterized by pustules, seropurulent discharge, crusting, and erosion, which heals with no scarring. Why there is no scarring? Because it does not involve the deeper tissues, because that is superficial. Whatever is a superficial infection will not produce scarring. So, superficial skin infections, commonly there will be pustules, seropurulent discharges. There can be crusting, which is nothing but the dried up exudates, and erosions, which heals with no scarring. Whereas the deep skin infections, they are characterized by skin lesions with induration. Induration is nothing but the thickness, tenderness, pain can be present on examination, on clinical examination. Then ulcers and lymph node, which may heal with scarring, and that's why it is known as a deep infection. Usually it is associated with constitutional symptoms. That's why there is a tenderness present. So, outline in brief, like primary pyodermas and secondary pyodermas. So this is the impetigo, the picture of impetigo. Usually impetigo, as I told you before, it is a superficial infection which mainly affects the children, and that is present periorally with, see, you can see here, honey colored crest. These are the honey colored dried up exudates or the crest. So whenever you see this type of a patient in your OPD, you can tell that it is impetigo. And this folliculitis, where you can see there is a pustule which is present in the hair follicle, in one single hair follicle. So for folliculitis, the clinical picture will be like a pustule in a single hair follicle. And see, even this is also folliculitis, where there is an inflammation, acute inflammation of the hair follicles. So Folliculitis will manifest as pustules, which are arising from the hair follicles. Again, this is another picture of folliculitis where you can see the pustules and the erythema. Erythema is also present, and that is from arising from each of the hair follicles. And this is nothing but psychosis barbae. Psychosis barbae, as the term suggests, it is like in the beard area, surrounding your mouth. This is nothing but psychosis barbae. And here we are discussing about nature of the course and how it is presented as. So the disease bullous impetigo usually is caused by Staph aureus, and it will be manifested as how it presents. It is present mainly in the face or extremities in the childhood age with thick walled bullae with pus. And the second one is non-bullous impetigo or impetigo contagiosa, where bullae-like presentation is absent. That's why it's a non-bullous impetigo, also known as impetigo contagiosa, which is caused by gas, GS, and Staph aureus. So it is present in a little more smaller children, right, in the preschool age group, and it presents as a thin-walled vesicles, rupture, honey-colored or golden or yellowish crust is present. It is spread by contiguity and auto-inoculation. As the child keeps on scratching, so it spread itself by auto-inoculation. And there will be associated regional knots and fever present, and it usually present in the face, around the mouth, nose and limbs. Then it can also be, there is an associated acute glomerulonephritis present. Next one is ecthyma. Ecthyma, the causative organism is GAS, and there is a thick chocolate adherent crust. So how can you differentiate between impetigo and ecthyma? In impetigo, there is just thick walled bullae with pus, or you can see honey colored crust. But if the crust is very adherent, and if there is an induration with erythema present, or if there is an ulcer which leaves with scarring, which is mainly over the lower limbs and buttocks, that is known as ecthyma. Coming to folliculitis part, so folliculitis, as I told before, it can be superficial folliculitis, which is caused by Staph aureus, and it can also be as a part of non-infectious disease. And how it presents is that there is a dome-shaped pustule or papule surrounding the hair follicles, scalp, or extremities. Second thing is psychosis barbae, which is caused by Staph aureus. So how it present is that it involves psychosis barbae. It's a deep infection. That's why it involves whole depth of the hair follicles of the beard, and there will be erythematous papules or papulopustules. Both papules and pustules you can see with a central hair, and it is healed with scarring, because psychosis barbae is a deeper infection, and psychosis barbae will be commonly present in the young males. Next is chronic folliculitis of the legs. So this mainly it is caused because of the dusty work or poor hygiene, or because of this oil massages and all. So these are the main reasons for chronic folliculitis of legs. And here the presentation will be follicular pustules, which are difficult to treat, and they will keep recurring and heals with atrophic scar. It is mainly present in the anterior aspect of the lower leg. Now we will see some pictures. Like this is the picture of furuncle. So furuncle means, it is involving the hair follicle, one single hair follicle. So that is involved, and we call it as a furuncle. And this is carbuncle. Carbuncle is usually seen in diabetic mellitus patients. So those people who are having diabetes, where there is it takes time to heal. And also carbuncle involves more than one hair follicle. When one hair follicle is involved, we can call it as a furuncle, and carbuncle means when the surrounding tissue, the surrounding hair follicle is also involved, we call it as carbuncle, and the main site is either in the lower abdomen or in the nape of the neck, the posterior nape of the neck, as you see in this picture. Next is like furuncle and carbuncle. How is it? So furuncle, what is another name of furuncle? It is boils. So boils are also known as furuncles, which is caused by Staph aureus. And here you can see deep necrotizing infection of a hair follicle with severe inflammation and suppuration. It's caused by Staph aureus. The predisposing factors are heat or diabetes mellitus, steroids also can cause boils. Clinically, there will be single or multiple tender papules and there will be induration present. Then induration, like indurated nodules will be present, which comes as necrotic, and discharge of the pus will also be seen. And if the lesion is on the cheek or the nose, it is known as cavernous sinus. It can lead to cavernous sinus thrombosis also. Yeah, because this is known as the dangerous part of the face. So whenever a boil you see in the cheek, this is spelling mistake, in the cheek or in the nose, it can lead to cavernous sinus thrombosis. So that's all about furuncles. So it is actually a hair follicle, which is hair follicle infection, which is superficial with a severe inflammation as well as suppuration. Coming to carbuncle, which is also caused by Staph aureus. So here a group of boils, that means a group of inflammatory as well as suppurated hair follicles you can see in carbuncle. So a group of boils which develops deep infection of the follicle, which is followed by an inflammatory change, as well as this change will also occur in the underlying subcutaneous fat. So initially it will come as a hard red nodular swelling, and later on there will be discharge of the pus from multiple orifices. So first it will appear like a hard red nodular swelling. Later there will be pus from the multiple orifices. Then it is also seen on the back of the neck, shoulder, hip and thighs. Precipitating factors are, like I told you before, diabetes mellitus, then steroid induced as well as immunosuppression. And this carbuncle will heal with scarring, and the dreaded complication will be septicemia and death. It is somewhat complicated. And this is the picture of cellulitis. You can see a diffuse erythema. Usually this occurs in the cellulitis is a deeper infection which is diffuse in nature. You cannot see a well-defined border will not be present, and cellulitis the patient will be having tenderness also. So here you can see erythema, edema, tenderness present. Okay, so this is a picture of cellulitis. Usually it occurs in the lower leg. Next, coming to erysipelas. This is the picture of erysipelas. So erysipelas is nothing but it is a superficial version. See, this is erysipelas, which mainly include on the, like you can see the erythema, edema present, which is seen superficially, and this is the involved areas will be like in this picture will be in the tip of the nose and the cheek. See, this is an abscess, like collection of pus. It is also a primary skin lesion. Coming to what is the difference between erysipelas, cellulitis, and abscess. So erysipelas, it is mainly in the upper, it involves the upper subcutaneous tissue with a marked dermal lymphatic vessel involvement, and it is caused by JAS or Staph aureus. There is a history of trauma or a throat infection present, because mainly this can be caused by Staph aureus or streptococcus also. So there will be a throat infection present. Is characterized by erythematous, edematous, painful, indurated plaque with sharply demarcated borders. In the infants, it will manifest in the face, the lower limb, the abdomen, and in adults, it usually involves the face, ears, and legs. Coming to cellulitis, it is caused by Staph aureus and GAS. It is differentiated from erysipelas by the diffuse, ill-defined, and diffuse hard swelling with erythema, and pain will be present. There will be a raised or localized raised temperature, which is associated with systemic symptoms, and diagnosis. The diabetes mellitus, it should be ruled out. So cellulitis means usually it involves the lower limbs, and clinically there will be diffuse hard swelling with erythema, pain, and raised temperature associated with, like, there will be erythema, edema, tenderness with systemic manifestations, and the diabetes mellitus have to be ruled out. Next is abscess. It is an acute bacterial infection characterized by collection of pus in the dermis, subcutaneous fat or muscle or deeper tissue, and it starts as a red, tender, like erythematous, painful nodule, which becomes extremely painful and soften within few days due to the collection of pus. Later it will rupture. So the predisposing factors we can call for abscess is obesity, diabetes mellitus, a hot climate, etc. And once an abscess develops, surgical treatment is mandated. So wherever there is pus, we have to drain it out. That is the rule. So this is like acute paronychia. Paronychia means it is nothing but it is an infection of a proximal nail fold or a distal nail fold. So here you can see there is an erythema and edema characterized by pus, which you can see as an yellowish color. So it is usually here in this picture it is present in the proximal nail fold. So it's a picture of acute paronychia, where you can see an acute inflammation of the proximal nail fold along with the lateral folds. Now, paronychia, it is inflammation of the nail folds. Acute, when it is present, it is acute. It is caused by bacterial infection. When it is chronic, it is due to candida, or that means it can be a fungal infection or a bacterial infection as well. Acute paronychia is caused by Staph aureus mainly. Clinically, the nail fold is separated from the nail bed, and there will be erythema, painful, tender with a purulent discharge present, and the treatment is systemic and local antibiotics. So you can give systemic as well as local antibiotic as well. Now, coming to the chronic paronychia, which is mainly caused by a fungus candida as well as some other bacteria. Predisposing factors are chronic immersion of the hands and feet in water, like for washerwoman and all. You can see a chronic paronychia. Then it can also come as like occupational related, those whoever are dealing with the chemicals. So due to the chronic handling of these chemicals, they can also get a chronic paronychia. Now, greenish discoloration of the nail plate may be due to Pseudomonas infection. As you know, like Pseudomonas infection mainly manifest as green in color. So greenish discoloration of the nail plate, if you're seeing, you can doubt your differential can be Pseudomonas nail infection as well. It is a chronic intermittent bacterial infection which results in dystrophy of the nail plate. So the treatment is topical antifungals and lacquers. Lacquers means like nail polish like application. So it is also helpful in chronic paronychia. So topical as well as fungal, antifungal lacquers can be given. And recurrence can be prevented by the use of finger gloves. So you have to tell the patient to avoid like direct coming in contact with the chemicals or water or something. So for that, what you will advise is you should advise the patient to use finger gloves. Coming to intertricho, it is again one of the main disease or main clinical presentation where the patient comes to you in the OPD. So predisposing factors of intertricho is obesity, humidity, as well as diabetes mellitus. So here the positive agents are Streptococcus, Pseudomonas, Candida, which is the main one of the main fungal part is Candida, and then dermatophytes. And patients will come with burning and itching as well as a watery discharge present on the bilateral growing folds. Now, clinically, the skin folds will be appearing as reddish. That is, erythema is present with macerated. Macerated means that wetty appearance, which will be seen clinically as a whitish colored change. So, clinically, you can see reddish, macerated, fissured, and painful appearance of the skin with foul smelling discharge present. So keeping the folds dry and avoiding the aggravating factors is the best advice you can give to the patients. Antifungal dusting powders like clotrimazole dusting powder can be given, as well as systemic antifungals are also helpful in such situations. Coming to Staphylococcus scarlet skin syndrome, its other name is Ritter's disease. So it is again a bacterial infection of the skin involving the larger areas. It is usually caused by Staphylococcus aureus, as the name suggests. Now, the infection occurring in the septic focus in the skin, nasopharynx, or the middle ear, and it can liberate this bacteria can liberate an exotoxin, which is also known as epidermolytic toxin. So, it is chiefly seen in infants and children, that is in the younger age group, and usually there is a history of an upper respiratory tract infection, which is more common with the Staphylococcus. Now, this infection will be followed. That means the upper respiratory tract infection will be followed suddenly by like whenever there's a development of a generalized erythema and tenderness of the skin, mainly on the face, trunk, and extremities. The child develops exfoliation of skin, that is scaling will be seen with a flaccid bulla. So the bulla means when it is fluid contained raised lesions which are more than 0.5 centimeters in size. Then there can be rupture, and this bullae can rupture and can produce painful erosions with a positive Nikolsky sign. Usually erosion heals without scarring because it is usually superficial and this scarring will occur within 1 to 2 weeks. The oral mucosa is usually spared in these cases. Treatment is IV antibiotics and IV fluids if essential. Prognosis is always good, but risk of mortality if treatment is not initiated promptly. So, have to treat as soon as possible. Outline in the disease caused by corniform bacterium. So cornybacterium, it also constitutes one of the normal skin flora like Staphylococcus or your E. coli. So this can become pathognomonic if it is present excessive in amount in your body. So like cornybacterium, pyogenes, cirrhosis, and minutismum, these are the various species. Clinically, they will be, how the patient presents to you will be with a malodorous axilla, trichomycosis axillaris, then erythrasma and pitted keratolysis. So all these features will be present. Pitted keratolysis is that spot-like thing which you can present, which you can see. Erythrasma will present usually as hyperpigmented erythematous plaque over the axillas. Next, malodorous axilla. Why there is a malodor is because of the regeneration of the apocrine sweat glands by this cornybacterium bacteria, which will result in a foul smelling, okay, from the axilla. Now, application of ethyl alcohol or antibacterial powder is essential for this. Coming to trichomycosis axillaris, it is characterized by yellowish to red, dirty-looking concretions on the axillary hairs, which is caused by Corynebacterium tennis. So, trichomycosis axillaris is the one where there will be yellowish, dirty-colored concretions present on bilateral axillae, which is caused by Corynebacterium tennis. It is treated by regular hair trimming. So, you should always ask the patient to trim the axillary hairs so that the bacteria cannot survive there. And you can also treat with 1% formalin application or benzoic acid or alum chloride. So this is a picture of erythrasma where you can see the hyperpigmented plaque which is seen in the skin fold. Usually it affects the skin fold. This is caused by Corynebacterium minutismum. So coming to erythrasma is caused by Corynebacterium minutismum. Predisposing factors are heat, humidity, hydration, poor hygiene in obese patients, you can see, as well as an immunocompromised like diabetes mellitus. Clinically, it is seen as asymptomatic reddish, brownish, black patch on the axillae, or it can also occur in the crural, genitocrural area, as well as the inframammary folds in females especially. Next, Wood slamp examination. It is a side test which we will do in the derm OP. So there you can see coral red fluorescence, and this coral red color is because of that bacteria, that minutismum bacteria, which will emit a coral red color on Wood slamp examination. And Wood slamp is the one which uses 365 nanometers of blue light. So the treatment of erythrasma, you can give fusidic acid, that is a topical antibiotic, as well as imidazoles. Imidazoles are also, that is antifungal, are also effective in this erythrasma. Then erythromycin can also be considered, like tablet erythromycin can also be considered. Now, pitted keratolysis, it comes as multiple tiny, round, shallow. It is not so deep. Crateriform lesions seen on the palms and soles due to proteolytic enzyme that digest the keratin and form the pits. So wherever there is a proteolytic enzyme, we know that proteolytic enzyme will digest all the proteins and it will digest the keratin and it can form the pits. So that is nothing but pitted keratolysis. The predisposing factors are excess sweating and those people who are handling more of the water or the wet, and those people who are having hyperhidrosis, that means excessive sweating. And the treatment is again fusidic acid and imidazoles. Then tablet erythromycin may also be useful. Coming to anthrax, which is caused by Bacillus anthracis, which is again a gram-positive bacilli. The 3 clinical forms are manifested for anthrax in humans. One is cutaneous anthrax, then inhalational anthrax. Coming to the third one, and that is gastrointestinal anthrax. So the first one, cutaneous anthrax, it is due to a direct contact with contaminated meat. Inhalational anthrax is due to inhalation of the spores. So inhalational, as the name suggests, it is due to inhalation of spores. Cutaneous anthrax is due to contaminated meat, and gastrointestinal anthrax due to the ingestion of contaminated meat or milk. Cutaneous anthrax, 95% of all the anthrax infection it constitutes. 90% of the lesion occurs on the face, neck, arms, and hands. It begins as painless pruritic papules within 3 to 10 days inoculation. Rapidly it progresses into vesicles It ulcerates with a central blackish scar that is the hallmark of anthrax, which is surrounded by a ring of vesicle within 36 hours, and there will be a perilesional edema. This disease may also progress to include a regional lymphadenopathy, leading to large swelling of the submandibular, the preauricular, the axillary, or the groin areas, and rarely it can lead to septicemia. Cutaneous anthrax, the most common form, usually it is curable. On the other hand, inhalational anthrax and the intestinal anthrax is often difficult. So even though cutaneous anthrax is the most common manifested form of anthrax, it can be treated. But inhalational and intestinal anthrax is very difficult to treat. And how can you diagnose? So diagnosis is by presence of difficult bacilli from the ulcer in gram staining. So you can do a gram staining, but you can see gram positive bacilli. Treatment: 20% of untreated case can develop bacteremia, it can include bacteremia, which can lead to death. And treatment is with penicillin G. Asymptomatic exposed case should be given prophylaxis with the doxycycline or ciprofloxacin for 6 weeks. So about 1.5 weeks, you should give prophylactic doxycycline or ciprofloxacin, and that is the prophylactic care for anthrax. Management of bacterial infection, like investigations, how you management always include investigation as well as treatment. So first of all, how will you investigate? Bacterial skin infections can be clinically diagnosed in most of the cases. In case of difficult ones only, you can go for a complete blood count, which can show leukocytosis and a raised ESR. So ESR and leukocytosis suggest it's a bacterial infection or there is some infection present. Now, gram staining to identify the specific organism, whether it is a cocci or a bacilli or a gram positive or negative. Gram positive appears as blue in color and gram negative appears as a pink color. KOH mountain to show gram positiveness of. KOH mountain means you can identify a fungus. You can see the fungal spores of hyphae. Now, swab culture and sensitivity for the isolation of the organism. Blood culture can be done for the deeper infection or where there is septicemia, and a biopsy in wherever necessary cases. What are the general principles? So, improve local hygiene. You should advise the patient to improve the local hygiene and elimination factors, like we should always try to avoid malnutrition, then steroid therapy, then diabetes, generalized debilitating condition, all have to be treated or avoided. Now the crust, it may lead to prolonged infection, and non-healing crust can be removed by soaking with saline water. Now local heat application can be suggested for pain and soften boils. This heat application, it will reduce the pain as well as it will soften the furuncles or boils or the edema. In case of a recurrent pyoderma, nose, ear, umbilicus and anus can be treated with local antibiotics like mupirocin, even if it is not affected. So as a prophylactic measure, wherever the patient comes with you with recurrent pyoderma, you can ask them to apply a topical antibiotic over the nose, ears, those cavities, umbilicus and the anus. So that's a prophylactic measure. So that's all about the bacterial skin infections. Thank you.